Welcome to the 9th episode of our iSense Q&A series. I am Erin Manning, the Communications Manager for the UCL-led iSense project, which is an EPSRC-funded interdisciplinary research collaboration focused on developing tools and technologies to track, test, and treat infectious diseases. This Q&A series is a chance to speak to and learn from experts working in the fields of infectious disease surveillance, testing, treatment, and beyond. Today we have the absolute pleasure of speaking to Prof Rebecca Shipley and Prof Ingemar Cox from University College London, and Associate Professor Alex Dickinson from the University of Southampton.
Super. Good afternoon, everyone. Thanks very much to Erin and the iSense team for organising it. It's a real pleasure to join the panel today. So I am Becky Shipley. I'm a Professor of Healthcare Engineering at UCL, so I'm based within the Mechanical Engineering Department, which is part of the Faculty of Engineering Sciences. And I'm also Director of our UCL Institute for Healthcare Engineering, which is a cross-faculty institute that essentially interfaces our healthcare engineering community with our medical and clinical science community across UCL, but also the hospital networks. And I'm on this panel, I think, because I also co-led the UCL Ventura CPAP work last year, which was essentially, well, it's ongoing, but it's a program that focused on designing and mass manufacturing non-invasive ventilators for treating COVID patients, first of all for the National Health Service, and then globally. So thank you very much.
Thanks very much, Rebecca, and thanks for joining us. Ingemar, would you like to give an introduction?
Okay, thanks, Erin. I'm a professor in the computer science department at UCL, and I'm one of the deputy directors of iSense, which is the early warning sensing systems for infectious diseases interdisciplinary research program that EPSRC funds and is led by UCL with Rachel McKendry as the director. We've been doing a lot of work on data analytics, particularly with regard to Google searches and their frequencies and how those can be interpreted to infer prevalence of diseases, in particular influenza. And I suppose I'm on the panel for the work we did that sort of took those ideas and redirected them towards COVID.
Thank you very much, Ingemar. And Alex.
Thanks very much. Thank you for the invitation to talk today. I'm Alex Dickinson. I'm an associate professor at the University of Southampton in mechanical engineering. Most of the time I work on design of prosthetic limbs, and quite by chance, sort of out of the blue, I got a call in March last year to work on a project developing a respirator device with colleagues at University Hospital Southampton to try and provide them with some slightly better respiratory protective equipment. And I think that's what I'm here to talk about today as well.
Thanks very much, Alex. My first question then, I'm going to start with Rebecca. So what were you working on before the pandemic? You gave us a little introduction now, and then how did that translate into the development of the CPAP machines for COVID-19? Perhaps can you tell us a little bit about what the CPAP machines were and how they worked as well?
Yeah, absolutely. So maybe I'll start a bit with my background and then I'll kind of briefly summarize the CPAP machine. So my background is actually as a mathematician. So I trained in applied maths and biomechanical modeling ultimately. So my research work is all around modeling things like blood flow in the microcirculation and understanding, using that as a tool to kind of understand signatures that you might observe in imaging data for both, healthy and diseased tissues. I also do a lot of work in tissue engineering applications, but it's all kind of that kind of framework of biomechanical modeling and blood flow and transport processes. And then my other kind of piece of my work life, if you like, is that, as I mentioned before, I'm director of the Institute of Healthcare Engineering, which is essentially focused on developing digital and medical technologies. So there's a strong focus there on translation and the translation of kind of foundational engineering approaches into technologies that are fit for purpose to be used in healthcare systems. And we've got a global angle to that as well. So that's kind of my background. In terms of the CPAP devices, so essentially we were a team that came together in March last year when the pandemic hit. And as many of you will remember, the UK was potentially in crisis. So China went first, then Italy, and then we started having exponential growth of COVID cases in the UK. And there were epidemiological models that were predicting that we might need up to 30,000 mechanical ventilators to treat COVID patients. We had about 3,000. So essentially there was a big gap that could potentially be disastrous. So we came together as a kind of collaborative team very quickly. So the background there in terms of how it came together was that I already had a collaborative grant funded by the EPSSE as well, actually, which is around modelling physiology of intensive care patients. So I worked with the intensive care consultants at University College London Hospital. And they were talking to colleagues in China and Italy whose experience was that when they were mechanically ventilating patients, their hospitals very quickly became overwhelmed and couldn't cope. And that their experience was that non-invasively ventilating patients, which is when you essentially provide pressurized oxygen to their lungs, it kind of blows open their lungs, if you like, and enables you to get more oxygen into their bloodstream than you would do with just a kind of unpressurized face mask. So that was enabling them to reduce the number of mechanically ventilated patients by about 60%. So essentially there could be a real role for providing better outcomes for COVID patients if we had enough CPAPs in the UK, as well as optimizing the resource that we had within our healthcare system. So essentially we formed a team working with numerous industry partners, including Mercedes high performance powertrains, who are the arm of Mercedes, who design and manufacture Formula One engines, to first design CPAP devices that were fit for purpose for the kind of constraints that we were facing for COVID, and then mass manufacture them, which we did. So we ended up making 10,000 of them by the 15th of April, which got deployed to 130 NH hospitals in the end. So my background before the CPAP work wasn't in working in ventilation or even lung models, but I think the relevant pieces were a lot of kind of engineering design and fluids modeling work, but also this kind of collaborative infrastructure, if you like, which really underpinned what we did. So I don't think we wouldn't have got very far very quickly unless we had the relationships with hospitals, with clinicians, and that kind of interdisciplinary approach to fixing problems.
Thanks very much, Rebecca. That's really interesting to hear the interdisciplinary approach that you had, and I'll come back to that with another question. But I'll hand over to Ingemar to maybe explain your background before the pandemic and the surveillance work that you've done for COVID-19.
Okay. So as part of iSense, we'd always been working quite closely with Public Health England, and we'd been developing early warning sensing systems for influenza. I mean, it's interesting that the government has this risk register, and in fact, they expected a pandemic to happen, but they were expecting it to be an influenza pandemic, not COVID, which was why we were focusing mainly on influenza during the last 5 years. So we sort of developed this work where we look at relative frequency of people's searches. This is aggregated over millions of people, and Google provides an API for doing that. And then we use machine learning algorithms looking at historical data from previous years to learn weights that then allow us to estimate the prevalence. And I guess around 2015-16, Public Health England and ourselves began evaluating that approach compared with their other surveillance systems. So they have a various set of surveillance tools, including a Sentinel doctor network, which is run by the Royal College of General Practitioners. We've written a couple of papers together with Public Health England about those evaluations and sort of demonstrated that we can often provide a sort of earlier warning of when influenza is going to increase, and also when it's going to peak, typically 1 or 2 weeks in advance of other systems. And I guess about maybe 4 years ago, Public Health England decided to incorporate software and algorithms into their weekly reports that they provide to government. So they've been doing that, as I say, for about 4 years. And I suppose around February or March of last year, Public Health England, approached us to talk about how we might repurpose those methods for COVID, which turned out to be non-trivial, mainly because of the lack of training data, which meant that although we could do something similar, we couldn't simply just turn the handle and relearn the weightings, etc. So the work we did with them on influenza, though, helped a lot in driving that forward. The other program of work that we'd done was looking at the effectiveness of influenza vaccines on children, and they had this model for influenza spreading, which indicated that children were a big spreader of the disease, and that if you could reduce influenza in the population of children, you'd reduce it in the general population, even if they hadn't been vaccinated. And the big question in evaluating those kind of public health interventions is to predict, what would have been the prevalence if they hadn't vaccinated the children, and what would be the difference. And so again, we'd worked with Public Health England on that and had some joint papers with them. And some of those algorithms we were able to repurpose together with Microsoft to allow us to not only do the national surveillance that I talked about, but also to do subnational upper tier local authority flagging of abnormalities. So where a local authority might be, we might expect that there's an unexpected outbreak of COVID cases, and that's also being provided to Public Health England now.
Thanks very much, Ingemar. And Alex, would you like to give an introduction about the machines that you developed?
Thank you. So I've been working for nearly 10 years on various sorts of lower limb musculoskeletal devices in engineering. And I lecture engineering design. So prior to this, I had no real knowledge about infectious disease or protective equipment or anything. Originally, I worked on developing hip replacement implants, and since about 2012, I've been building a research team where we investigate how prosthetists produce the bespoke part of the prosthetic leg, which attaches it to the user's residual limb or stump, and how we can give them database tools to reduce the trial and improvement elements of their work. So all quite different from protective equipment. But I got an email last thing on Monday, the 16th of March last year. It was from Professor Paul Elkington, who's a respiratory doctor at University Hospital Southampton, and Prof Howell Morgan, who's an electronic engineer at the University of Southampton. And it came through our Institute for Life Sciences, who are a great collaborative networking organization inside the university. And they were looking for a can-do mechanical engineer to get involved in a project, and somebody decided to forward it to me. But Paul had been called away from his TB research work onto the wards at University Hospital Southampton, was really concerned about how the situation was escalating, and wanted to see if we could produce some more protective and more comfortable respiratory protective equipment for the UHS staff than the FFP2 and 3 masks that they were currently using. And I had a special interest in the anaesthetists and various staff working on higher risk and more aerosol generating procedures. So on the Tuesday morning, I guess that was 17th of March, we were a team of 4, and by the Friday afternoon we were a team of 8, and we had a working prototype that we demonstrated to UHS management on that Friday evening. Paul had given us a sketch of a powered air purifying respirator, we'll call that PAPR, and that's what we developed into Perso. And PAPR is different from a mask type respirator that that fits snugly onto the skin on the front of your face, because it uses a fan to draw air through a filter, and it delivers it up a pipe up the back of the wearer's neck and into a hood, positive pressure. So in theory, it rules out the inward air leakage that you might get around the edge of a mask. It should fit everybody, because there was some evidence that a not insignificant proportion of healthcare workers found that none of the standard respirator masks fitted their face shapes. And because it's worn like a hood with a frame like inside a bike helmet or a hard hat, it should fit more comfortably and for much longer periods, like a sort of 8 or 8+ hour NHS shift, than the mask will when it needs a real tight seal on the face, so it presses on the relatively delicate skin on the face. And in theory, it stops the person touching their face as well, because we believed at that point, it may well be the case for the healthcare workers, that there's a particular infection risk just by touching your own face. So we developed Perso, and we were aiming for a very low-cost device, as much as possible using off-the-shelf components and simple manufacturing methods and steps. We were initially really primarily concerned with the staff at University Hospital Southampton, but Paul and I both lead Global Challenges Research Fund projects. Paul's on tuberculosis by Medical Research Council funding, and the one I led was on prosthetics by EPSRC and NIHR. So we recognised the need for lower and middle income countries would be following very soon. So we tried to come up with something that was as simple and as open sourceable as possible, so that it would have as wide a benefit as possible.
Thanks very much, Alex. It's incredible to hear how quickly you came up with the designs for Perso as well. Rebecca, I'm going to come back to you. You mentioned an interdisciplinary team that you worked with. And I wanted to ask, how did you use your existing network, and how did you engage with new partners to come up with the final designs of your tool?
Thanks, Erin. Yes, so I think we had a kind of combination of both. So you know, a bit like Alex's story, it was really clear that if we were going to be able to do anything, we had to move really quickly. So I think in that situation, you naturally look to your existing networks and the established networks that you're a part of. So as I mentioned before, I'm very pro kind of interdisciplinary collaboration. That's a big part of what I do, and it's a big part of what we've tried to develop as a culture within the Institute of Healthcare Engineering. So essentially, as I said before, I already worked with the critical care teams at UCLH. It was really important that obviously we had the healthcare experts kind of driving they're the users of the technology, right? So they had to be driving the need, and we needed that ecosystem where we had access to hospitals for continuous testing, etc. as well. So that, so we were already linked, and that was fantastic. But we needed healthcare, we needed engineering expertise, which obviously we had at UCL. We needed the mechanical engineering expertise. I'm in the mechanical engineering department, and then we needed manufacturing capability. So the other kind of really important piece of the puzzle was that within the mechanical engineering department at UCL, I've got a colleague, Professor Tim Baker, who basically does kind of engineering design, and he worked in the motorsports industry for quite a long time before coming back to UCL. So I reached out to Tim, who immediately reached out to some of his motorsport colleagues, because the manufacturing piece would mean that we would need that capability to manufacture very quickly. And as luck would have it, or not luck, it was an inevitable consequence of COVID, the Formula One racing season had been stood down. So essentially what happened was that we went for a drink in the Houseman room, which is the senior common room at UCL, and with Mervyn Singer, who is the crit care consultant at University College London Hospital, myself, and Tim Baker. Mervyn, as I mentioned, had been talking to colleagues in China and Italy about the role of non-invasive ventilation, or CPAPs. So he kind of laid down the gauntlet around working on CPAP devices instead of mechanical ventilators. We rang Mercedes HPP that evening, so a chap called Andy Calder, who was their managing director at the time. And his response was, do not hesitate to call on the full might of what we can do. So as a response, when you reach out to industry, that's pretty phenomenal, right? That doesn't often happen in usual times. So I think we were very lucky that we had that kind of response. But again, it kind of points back to these kind of existing networks that span different disciplines within academia, but also academia, healthcare, and industry. And that kind of ecosystem was essentially already in place. And the Mercedes teams arrived at UCL the next day. We bunkered down in the mech space, which is a dedicated engineering design facility as part of the mechanical engineering department. And essentially that enabled us to move very quickly. And again, it was that kind of common space and infrastructure and investment. So we had engineering design facilities. We were about 10 minutes walk from University College London Hospital, where we were able to just, you know, we already worked with those teams. We could go straight down there. We could be testing devices in the hospital kind of at no notice. So from the team forming, because of all of these kind of established networks are in place, we were able to move from a standing start to within 100 hours, we had the first prototypes made. So we designed them. It was a reverse engineered replica of an existing device that was previously CE marked but out of patent. And within 100 hours, Mercedes had driven back to London, having manufactured the first couple, and we were in the hospital testing them. So that was obviously very quick. And we got regulatory approval for that within 10 days of our start. And then we did a lot of work on a version 2 device, which was essentially motivated by reducing the oxygen utilization. So I think, again, many people might have read about over the last year or so that because of the unprecedented number of patients who need oxygen support in hospitals, hospital oxygen supply systems have been under a lot of strain. So there was a potential that we might run out of oxygen, or individual hospitals might. So anything that we could do to reduce the amount of oxygen that these devices used while still providing the same therapy, if you like, to the patients was very valuable. So we made a Mark II that essentially reduced the oxygen utilization by up to 70%, and that's what went forward for mass manufacture. But all of that kind of piece was enabled by, first of all, the kind of understanding from the healthcare experts on what was a valuable treatment modality for COVID patients and how it would work within the hospital infrastructure systems. And then having the combination of the engineering capability, the modeling, you know, the fluids modeling capability to inform design development, and then that manufacturing capability, which meant that that piece could be done very quickly. And as I said, I mean, Mercedes HPP were phenomenal. At their maximum rate, they were making 1,200 a day. So they repurposed their whole factory setting. So it was a rather long answer to your question, but hopefully kind of explains all of the networks are in place. I guess the only other piece that is also really important was we ended up working with a range of other SMEs, so smaller companies. Obviously, Mercedes HPP is a very large established outfit, but there was a real role for smaller companies as well. So because of the demands on healthcare technologies globally, there was supply constraints, which meant that we couldn't get access to things like oxygen monitors and all this kind of stuff. So we ended up going through a similar process with various different smaller companies to essentially design, for example, oxygen analyzers which could measure the concentration of oxygen that was being held by a patient, because essentially we just couldn't import them into the UK at the time. They were needed all over the world. So again, they're very small companies that had expertise in different areas. So again, worked in things like the automotive industry or motorsports industry, were very nimble and were able to repurpose their expertise. And we also worked with a company called Avon Security, who normally do kind of contracts, for example, and they might make biosecurity kits. So we worked with them on a CPAP hood, which is like it's a hood that sits over the patient basically and connects to the flow generator and delivers the oxygen into the patient. So, you know, I think, again, being able to reach out to a range of different fields of the engineering kind of manufacture industry that hadn't worked in healthcare particularly before, but all were very motivated to contribute to COVID was very valuable.
Thanks very much, Rebecca. It's amazing to hear people being so adaptable to change as well. Alex, I know you explained a little bit about working with other people within University of Southampton. Did you want to elaborate on maybe the partners in the manufacturing process as well, and how those collaborations kind of came about?
Sure, yeah, thank you. So I think I mentioned we had the Institute for Life Sciences who set up quite a lot of our internal collaborations, and that's really what they do. They look at bringing together all of the really quite disparate life sciences activities that go on across a bigger university as Southampton. So we have people, obviously in the faculty I work in, medicine, health sciences, into humanities and even archaeology. So one of the good things about this project was we were able to bring together enough people who were confident enough about the various different parts of a device like a respirator that they could develop them, and technicians as well. And most of our internal workshops were pretty quiet at this point because most of our students had gone home. So all of the students working on dissertation projects where they would have been building prototypes weren't really able to access the labs anymore. So we give them an intensive design activity every January, and we give them a design brief, and we were using exactly the same equipment as we give them, and we had a similar design brief to what we give them. So at least next year we'll be able to tell the students we went through exactly the same thing. But what was interesting was some of the other networks outside Southampton that we were able to bring in. So several of us work on quite large technical consultancy jobs, and Dr. Mark Mavrogadata, who runs our micro CT imaging centre, does lots of commercial consultancy work. So he was able to bring in prototype development partners at McLaren Racing, who prototyped our headgear. And we're on the south coast, we're in close to Ocean Village, we're in Yacht Racing Central, so we had a couple of sailors on the team as well. And they meant we're able to get some advice from NGO Sales, and we got prototype hoods manufactured by Kemp Sales, who are far better on a sewing machine than I am, and we're able to do things much more quickly and higher quality. Crucial was partnering with Indo Lighting, who are a local SME, and they developed a real productized version of the prototype, and they obtained regulatory approval eventually. So quite similar to Becky's story, we had 2 stages, almost 3 stages. So we had a prototype and a specification that we published. We then had a first round prototype that was really a development of an existing respirator, and then I think the Perso 1 is the latest stage that's really a new device based on the standard that we developed. So I think that was a sign of us all doing what we're best at. So we were quite good at the development ideas at the university, but I think a key point was recognizing that we couldn't manufacture things at scale. That's not what we can do, and so we needed to bring in partners that had slack in their production lines, as Becky said, and we're keen to help, so they could help on the major aspects of quality engineering, manufacturing at scale, and regulatory.
Thanks very much for sharing that, Alex. Ingemar, I have a question for you about your models. So they showed quite successful early on in the pandemic, picking up things like loss of taste and smell, being a symptom of COVID before that was widely known. What are some of the processes that you needed to go through to ensure that the models were accurate, and any ethical approvals that you needed to go through to?
Sure, Erin. Well, let me deal with the ethical end first. There are 2 pieces of work that we did for Public Health England, where we're estimating sort of prevalence nationally or abnormalities subnationally. There we didn't need ethics approval because the data that we get from Google isn't personal data, but it's aggregated data over millions of people. So there were no ethical issues there, and we've already been doing similar work with regard to influenza. So we were fortunate there. Subsequently, we have tried to do work with Twitter for a slightly different topic, and there significant ethical issues arose. In particular, one was in the interpretation of the terms and conditions of use of Twitter data, and whether we were inferring health information or not, which Twitter expressly says you should not do. And the other was with regard to informed consent, where it was agreed that a Twitter user had essentially consented to the use of their data based on the terms and conditions that they sign up for. But what was more complicated was that we were also interested in tweets of the form, "My spouse, my child has COVID." And in that case, it was very unlikely that the spouse or child had actually given any consent for that information to be made public. And so there was considerable discussion about what to do there. But we did eventually resolve those issues and working on the Twitter data now. But going back to Public Health England, of course, evaluating the quality of the outputs that we're producing is actually a bit tricky, because nobody really knows the underlying data without doing a huge amount of testing on a random population. But we developed the model for Public Health England. We looked at sort of typical measures like correlation, and sort of demonstrated that an advantage of our system was that we were sort of giving Public Health England 2 or 3 weeks early warning compared with case counts or excess deaths. We also checked our work not just based on data from England, but on data from about 8 different countries, including 3 or 4 in Europe, the US, South Africa, and we were getting sort of consistent results across the board. So I think that gave Public Health England some confidence that that the information we were giving them was useful.
Thanks very much for sharing, Ingemar. I have a question from someone in the chat. They ask, are there specific challenges and lessons that you learned rapidly developing and manufacturing a new product in response to a global pandemic? Maybe Rebecca, would you like to start?
Yeah, I mean, that's an excellent question. There's a huge amount that we've learned, and I think there's a lot that was different about the situation that we faced that that meant that we could move quickly, and it would be brilliant to try and kind of replicate that, or some of that at least, in normal times. So for us at least, I think there were numerous pieces of the puzzle which meant that we could move quickly. One of the big pieces actually was a kind of reduction in bureaucracy and a tend towards much more open communication and collaboration. I mean, certainly the fact that there was this, potentially massive crisis, well, it was a massive crisis, coming towards us, meant that, whoever you reached out to, whether it was academic, industry, government, regulation, were all very focused on trying to tackle the problem in hand. So there was that urgency of need, which was incredibly motivating and driving, which obviously we don't have in kind of normal times, if you like, but did really bring out the best in people in many ways and bring people together. The other piece I think that was really pivotal for us at least was pivoting of kind of regulatory processes, so and bureaucracy in that sense. I think anyone who works in medical devices will know that it can take 5 to 10 years from kind of development of a medical device to get it through all of the stages of regulatory approval, right through to kind of deployment into healthcare, and that's a long process, and there's a lot of reasons, very, very good reasons why that is such a long process, because obviously these devices have to be safe and effective. I think we were able to move quickly for a couple of reasons within that environment. First of all, we started off by replicating a previously CE marked off-patent device, which meant that our Mark 1 was an exact replica of that, and we had to demonstrate that in extensive detail. But because there was that existing clinical user base and evidence base for those devices, that obviously meant from a regulatory perspective, we were off to a quick start, and that is exactly why we took that approach. But the other thing was that the MHRA, who are the UK regulator for medical devices, really pivoted their regulatory processes. So it was obviously very important that they maintained the same levels of standards around safety and efficacy. But it was a very different environment. So, I remember we reached out to them on the second day that we had been working together. We emailed them late at night it was something like 10 o'clock in the evening, and the chief exec there, Jean Rain, replied within about 5 minutes. And from the next day onwards, I was speaking to the regulatory teams there multiple times a day. So there was very open communication. They were very clear about exactly what we needed to do and what standards need to be met in order to be granted regulatory approvals. So there are actually special authorizations. So, you know, these devices can't be used on any patients. They can only be used on COVID patients under very special conditions. But that kind of transparency around process and clarity on what needed to be done was extremely helpful. And in the end, we went from our first meeting to getting the special authorization for our Mark 1 device in 10 days. And then it was 2 days later that we got the approval for our Mark 2 device, which was the one that minimized oxygen utilization and went into mass manufacture. So I think that really helped an enormous amount. And you know, there were similar learnings from working in the hospital environment, you know, ethics, clinical evaluations, which we needed to do both at University College Hospital and across sister hospitals. Usually there would be an incredible amount of bureaucracy involved in being able to do all of those things. But again, because of the urgency, we were able to turn around each of those kind of applications, if you like, within a day. So we could move very quickly. Now, of course, like moving forwards, there has to be a balance. You know, I don't think the extremes of one or the other is ever appropriate, but I think there's a potential to learn a lot about how we, and especially, you know, we have got an opportunity at the moment, particularly in the regulatory space because of Brexit, to reconsider some of our regulatory processes. And, you know, there's an opportunity to learn quite a lot there. The other piece, which I haven't talked about much, and I'm conscious of time and not taking up too much of the discussion, but is the global piece. So we ended up releasing all of our blueprints, so our designs and manufacturing instructions open source, through a kind of a legal licensing process, so that manufacturing hubs could be established in other countries. And long story short, they were taken up quite significantly, and there's about 20 countries now that have gone through the whole process of manufacture in country through to using them in hospitals, which has been phenomenal. But it's been very illuminating about all of the barriers that there are to doing that, and those barriers span kind of every piece of the puzzle, if you like, from supply chains for access to materials and components, through to funding, through to regulation. So the international regulatory landscape is incredibly fragmented. The MHRA were again fantastic, and they offered to speak to regulators in other countries. So they spoke to regulators in Pakistan, in South Africa, etc., so that there could be communication around what we'd done in the UK and what would be appropriate in other countries. Yeah, so there's a huge amount to be learned, and there's a huge amount that's still a massive challenge. You know, our international work is still very much ongoing. We got an email this morning from a team in Iran who are mass manufacturing the devices and supplying them to neighboring countries, which is fantastic. But for example, that team can't get access to the breathing circuits. They can't import them. There's no supply chain for them, and they've had to import all of the subcomponents for the CPAP devices from China. And it's incredibly complex. So I'm not entirely convinced that if we hadn't, you know, if COVID were to stop tomorrow, which we're very far away from that situation, it's getting worse if anything. If we had another pandemic, it's not particularly clear to me that the global situation is much further along the process of being improved in terms of international collaboration and lack of isolationism than we were before.
Thanks very much for sharing, Rebecca. Alex, would you like to expand on what Rebecca said and share any key challenges or lessons that you've learned? You're just on mute, sorry, Alex.
Muted. Yeah, it's quite similar to several of our experiences. So I think you got a little bit further on the international developments than we did. Huge congratulations for that. So we found that regulatory approval was a challenge. So we were able to take advantage of some BASE instructions to the Office of Product Safety and Standards in, I think it was March or April last year, about regulatory easing for people who were working on non-novel PPE, so that they could get quicker from prototypes into products. But it did take quite a long time to get proper regulatory approval, even though the challenge for us was that compared to a surgical mask, at least, we couldn't see any way that these devices could be putting anybody under under greater risk. So it was a sort of internal tensions, I guess, in wanting to follow the right pathway, but also seeing it being really quite a no-brainer that people should be wearing these things for some, at least no worse protection. A key partner for us was with the infection control team at UHS, and they developed some safe use protocols for these devices. So donning them the correct way, decontaminating them, and then taking them off, so that we were relatively confident that users wouldn't end up infecting themselves just by taking a used respirator off. And that's probably one of the main reasons that we sort of trod carefully around how we released the news about the project we were working on. We wanted to tell people so that we could get support, and so that we wouldn't be duplicating efforts if other people were working on the same thing. But equally, we were concerned that members of the general public might think, well, where can I get one? Can I make one? There was a real limit to the components that were available in the country, and these wouldn't necessarily be appropriate for the level of risk that the general public were under, where they definitely were for people in hospitals, and potentially you cause greater risks of general public members infecting themselves using this wrong. I think the other essential thing for us that Becky also mentioned was open sourcing. So we didn't want to protect or hide the design. We definitely didn't invent the powered air purified respirator. That I think the first standard for how you develop and test them was published in 1998. So we never pretended to create it, but we just wanted to get the designs online. And that took lots of extra jobs like you wouldn't expect. So Becky mentioned the device that was out of patent. We knew that there were plenty of patents around PAPR, but we didn't know exactly what they were. We weren't working with a PAPR manufacturer. We did try and get hold of some. We were able to purchase one because there were no imports, and stocks were very limited, and that was with an NHS email address. We needed to make sure that we weren't inadvertently breaching somebody else's patent, because even though it might be rather mean for them to go after us during the pandemic, if we're publishing something open source and there's a risk of secondary infringement, it's published forever. So we had to be relatively sure that we weren't infringing. And we were torn between all of these risks against the risk of not acting, not developing anything. Based on the stories that we were hearing from the healthcare workers at UHS, we had to do something. So there was sort of, I suppose, internal tensions there on desperately wanting to do something, but wanting to do it the right way and not cause more harm.
Ingemar, do you have anything you would like to add to what Becky and Alex have said in terms of challenges?
Only briefly. I mean, I think compared with Alex and Rebecca, we had it very easy because, our end user was Public Health England. We were already collaborating with them. It's software, so there's no sort of manufacturing issues. There were no regulatory issues. So in that regard, it was relatively easy. I mean, the issues that came up to us, not so much in those particular efforts, but in subsequent efforts, were access to data. And they're actually, I feel like our experience was not altogether positive. I mean, we spent a lot of time talking to telecoms, mobile device companies about access to mobility data. And that took a long time to get the contracts. The contracts were then basically free data for 3 months, and then very high charges for anything subsequent to that. The individuals at Google really helped, but as a company, we asked for specific data and we never got it. Some of it, understandably, they had concerns about privacy, but on the other hand, it took them almost a year to give us subnational data, and it's taken us a long time to actually understand what they've given us, in that it's not directly the same as the type of data we were previously working with. Thanks.
Thanks very much for sharing, Ingemar. I'm conscious of time, but I wanted just one quick key learning or takeaway that you've had from your experience that you would like everyone here to take away with them. Maybe Becky, would you like to start?
Yeah, absolutely. I mean, maybe it's a kind of point of reflection or learning for me as an individual, but you know, until COVID, I hadn't worked in any global health projects. So I think looking back, I was just phenomenally naive about a lot of the problems that were faced in medicine and in medical technology for the vast majority of countries across the world, you know, in particular, obviously low middle income countries. So I kind of feel I've been on this kind of rapid journey of learning much more about these areas, you know, both in terms of kind of challenges of treating people in different kind of resource settings, you know, access to kit, and you know, access to things that we just absolutely take for granted. So I think medical oxygen is a really good example of that. You know, if you're sick in the UK, you just don't even think about the fact that you can get admitted to a hospital and there will be oxygen available to treat you or someone in your family, whereas that's just patently not the case for probably most countries in the world. And that was a problem that preceded COVID by a long way. So, you know, pneumonia, you know, the number of kids that die every day, even of pneumonia because of lack of access to oxygen globally, is phenomenal. So I think for me, it's been this kind of process of learning much more about the reality for many people, and you know, where medical technology can help, where it doesn't help, and you know, I've learned a lot about building partnerships and working with people in a whole bunch of different countries, which has been just amazing. But I think for me, it's really kind of shone a light on how much more we could do and should do. and as I say, I'm still very much on that journey of learning much more. But I hope kind of personally, it's an area that I'll continue working in for a long time. So that will be quite a big shift for me in terms of my kind of academic work, I think.
Thanks very much for sharing, Becky and Alex.
Thanks. So I think something I'm going to take back into, or I'm taking back into what I normally do, is just making all those extra efforts on user-centered design. I think we quite often as engineers can be quite good at developing, you know, a toy or using a new technique we've got, and not always considering as carefully as we should and as objectively as we should what the users actually need. So we were developing something where the respirators that were given to the anaesthetists were all mounted on the head. They passed the standard for mass, but you had the fan, the batteries, everything on the headband, which is fine if you're welding or painting, but if you're trying to do CPR or if you're running to a code in a hospital, it's going to move all over the place. And there's a lot of literature as well, not just in PPE, but about design not being particularly inclusive, and often these kinds of safety or protective devices being developed to fit men and then really not being as effective at all in female users. So we something I want to keep trying to develop further is making sure that we're working with users as carefully as possible to understand what they really need instead of assuming it, and yeah, taking some of this and sharing as much of it as we can with our students. We've got an exciting case study, as I said. Now we can say that we really did it instead of just lecturing about it.
Yeah, amazing. Thanks, Alex. And Ingemar, any key learnings that you'd like to share with everyone?
Well, when I reflect back, I feel like we could have done more, but that it was great that there was short-term funding that came quickly, but at the same time, that was really problematic with regard to recruitment. It's hard to hire a really top-tier postdoctoral research associate in 2 months. They're just not available. Similarly, I think we could have done a lot more with the data, particularly if we'd been more familiar with it, but we weren't. And I guess that leads me, perhaps it's self-serving, but to the need for long-term funding this kind of work. So you know, there presumably may well be another pandemic, and perhaps we could be better prepared for that.
Thanks, Ingemar. We've gone a little bit over time. I'm sorry to take up more of your time, but thank you for being so generous and sharing your experience. And it's been really interesting to hear the interdisciplinary collaboration and how quickly you guys worked to respond to the pandemic. So thank you for all your work during COVID and for joining us today.
Thanks, Erin.
Thank you.
Thank you for having me.
No problem. Thanks for joining, Becky.